The views expressed on the Jerry Cahill's CF podcast are that of Jerry Cahill and guests, and not necessarily those of the Boomer Esiason Foundation. Nothing on the Jerry Cahill's CF podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Boomer Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor.
Welcome to Jerry Cahill's CF podcast series, The Path Forward with Cystic Fibrosis. This podcast has been sponsored through an educational program from Columbia University Medial Center and the Lung Transplant Project to the Boomer Esiason Foundation. Today we'll be speaking to Dr. Frank DeVidio about Ex Vivo lung perfusion. Because so many donor lungs are damaged at the time of death, only 20 to 30% of donated lungs are usable for transplantation. Ex Vivo lung perfusion is a process of evaluating and preparing donor lungs outside the body prior to transplant surgery. This could expand the available donor pool, which is extremely exciting for people waiting for a transplant. Dr. DeVidio will explain the process in the following podcast.
The concept is a ventilator, a perfusion pump, and the machine, as well as the opportunity to monitor airway pressures, pulmonary artery pressures, all the parameters that are needed to an in-depth physiologic assessment of the organ. We've implemented it as to further assess, but again, always utilizing our clinical judgment up front. So many times a CAT scan may suggest that the lungs are no good, but ultimately they are pristine. As you go in, reopen them up, manipulate them, you see them, they're fine, they're perfect. On the other hand, sometimes they are not good, and sometimes you have that doubt whether you could utilize them or not. And so that's where the Ex Vivo currently, today, has a role. We've capitalized on the Ex Vivo experience significantly because it allowed us to be more aggressive. We said, well, now we'll go and take a look at more donors, and if needed, we have any concerns, we bring them back and we can further test them. It becomes a clinical tool once we figure out how to maintain the organs for longer time, and that is the goal. Treat the organs before implanting. And priming them to become a better organ. The evolution of that is, how can we bring this methodology to support the organ for days, for weeks? So to allow us not only just to assess, but ultimately to treat. And that is where the field is actually moving, and likely where the methodology will gain its greatest implementation. Because then if you consider that of all donors, we usually quote that 20 to 30% of multi-organ donors end up donating lungs. If we even capture another 20, we're doubling the number of transplants that we could potentially perform. The opportunity of the Ex Vivo is potentially to bring the blood from the donor, bring the organs, temporize the organs on the Ex Vivo as we're assessing them or maintaining them a bit, complete the cross-match, get that information, and then transplant. So expanding the time of preservation is one opportunity that the methodology can be utilized from a logistical standpoint. If we reach the condition where we can support the organs over time, that's the vision. In other words, instead of having a Ex Vivo assessment, we will have a ICU for organs. In other words, an organ care unit, not an intensive care unit for organs. And that is the overall concept that we have. Instead of having the patient, we have the lungs. We have to develop the methodology to support the organ for days.